Okay, I wanted to welcome everybody for coming out to the talk tonight. My name is Tom Plut. I'm one of the sports medicine physicians at Lourdes. I wanted to welcome you to Lourdes. This is our new facility at Lourdes Care here, offering multi-specialty groups. So it's a brand new facility, and thank you for coming. So Sandy asked me to say this before I forget. The other thing that's not up there is if you don't have an evaluation form, please grab one, and if you want CME credit on the back of it, put your name and address and choose the word legible. So I'll let you define what that is. So I don't have any relevant disclosures. Tenex Health is the only entity that has proprietary ownership of the FAST technique. And before I get into the talk, a lot of times I get this question, how many cases have you done? Since we started doing this at Lourdes, I believe it's in October, to this date I've done 71 cases of all the major body parts that it's indicated for. So the goals today are to talk about tendinosis. That's what one of the main indications for the FAST technique is for tendinosis. So I always ask this when I've given this talk, what is tendinosis? Does anybody have any insight into that? This can be interactive. I prefer interaction. Yes?
Your tendon hurts because it's overused, and some people are susceptible to it. There's tiny little tears, and the collagen doesn't heal itself real neat.
Okay. Anybody else? So the main thing about tendinosis is it's not inflammation. It's thickened and degeneration. The way I'm giving this talk is how the best way to describe it to the patient. The take-home message is that there is no inflammation. There's thickening and degeneration. So I often describe it to the patient as scar tissue, and the tendons that used to be running nice and parallel with one another are now disarrayed. As of early 2013, neovascularization is now being questioned, but I still include it here because it's still a characteristic hallmark sign, which we'll see soon in later slides. But you have to know that it's not inflammation. That's the purpose of the FAST technique is to go after tendinotic tissue, not tendinitis. But you'll see in some of the video, people often will use the words tendinitis, but as long as you know what it's for the FAST technique is for tendinosis, that's the take-home message. This is an example of one of my patients, and this is my ultrasound probe, and the signal is headed towards the heel bone, the calcaneus here. And the image is generated, here's the calcaneus, because bone on ultrasound is hyperechoic. It reflects sound back. And then right here is the plantar fascia as it comes in. So this is relatively normal. It's a little wavy, but then this is abnormal, and that's a sign of tendinosis scar tissue. It's lack of signal, anechoic, or hypoechoic, intertwined within hyperechoic. So, and another thing just to remember is thickening. For this case, anything over 4 millimeters is considered tendinopathy for plantar fascia. So a lot of the patients, when we're looking with ultrasound, when my cases on average, they're around 6 to 8 millimeters of thickness. Another picture describing the tendinopathy here. This is an example of neovascularization. It's the body's attempt to heal itself by sending in new blood flow. And sometimes our earlier treatments before the FAST technique came out are to try to promote inflammation and treat this. This is the tennis elbow here. My probe would be right about here, and this is the lateral epicondyle, the flat surface, and where the extensor complex attaches right here. So neovascularization, and then again tendinosis. This should be glistening white. So as we get into the FAST technique, the instrument was developed. It's going on 1.5 years now, and like I said, we started doing it at Lourdes in October. Dr. Craig Kimmel and I have been, and we've had great success. And it's a topic that is becoming so exciting to me that my wife is probably sick and tired of hearing about it. But we actually, probably the first time that I've used the words, and I know Craig Kimmel has used the words, it's a game changer because we've seen such significant results so quickly. It's quite amazing. So before I forget, I have some examples of the handheld device. If you guys can pass these around, and to get an idea of what the handheld device is. I often describe it with my patients as like the big fat pencil that when you learned how to write earlier on in your education, and it's attached to about a size of an 18 gauge needle, about 1.25 inches. This is the console that delivers the ultrasound energy, as well as the irrigation and aspiration continuously while you're doing the procedure. And then this is a closer look at the handheld device. I put this picture up here just to remind me of what was being offered before the FAST came out a little less than 2 years ago. And the traditional open procedure. And you can only imagine the size of incision that is and the amount of trauma that is done to tissue. And this is where the FAST technique has been a big win because, as you can see on the handheld device being passed out, we're talking about 3 millimeters in diameter, an 18 gauge needle, if you will, to treat tendinosis instead of an inch or larger incision. So about the FAST. This is a nice thing about the FAST is before the FAST, as a non-op sports med doc, what I was offering was, the dry needling, the fenestration technique as well as PRP. But the current data on that from up to 2012 is it's around 30 to 50% success rate. And it's all over the board, especially with PRP, what protocols and what instrument you're using to get your PRP. And to be honest with you, it's not as consistent as the FAST. And you know what you're going to get from as long as you know how to use the equipment and use ultrasound, you get pretty consistent results. We were talking about this before the talk. It's FDA approved. PRP is still considered experimental. It is being reimbursed. It's cost effective. It's safe. There's so many pluses to it. It's minimally invasive. For example, the 18 gauge needle incision, a lot of times when they come back a week or two, you don't even see where the procedure was done. And the nice thing about it is it can be done in your office or, if you so choose, at an ambulatory surgical center. People always ask, well, how long is it going to take? For a tennis elbow, you're using about 30 to 60 seconds of ultrasound energy. But as you move down in the lower extremity, like a patellar tendon or an Achilles tendon, or sometimes plantar fascia, you might be going from the 1 minute to 2 minute mark. In some cases, which we'll see soon, I've used 2 minutes on a patellar tendon because of the amount of diseased tissue that was present. And if you remember that slide about that open procedure, recovery time, especially for the FAST, is by far a lot shorter. And that's a big plus for it, especially in our culture and in our society. So I always like to put this slide up there as a representative as a clinician representing the technique. And I always like to be honest with myself. Right now, the best evidence we have are prospective trials. We don't have the RCTs, the best studies, but as you know, in your learning, you go with the best information, what you have. And as of right now, I can honestly say, you can say, well, a lot of this data is derived from 10x, and that produces a bias. So that being said, when I started doing these, I read through what their literature was, and I've been getting the same amount of data that they've been getting. The 80% success rate, the high patient satisfaction scores of 95% or better. So it adds a lot more value to me because, if the company's producing the information, you have to question, there's a bias there. And research is starting right now, independent people, clinicians that are not working for the company to get their own research, and it definitely needs to be done. but you have to start somewhere. These 3 points are important. From a patient perspective, everybody cares about decreased pain and improved function. And that's what we care about. That's patient-oriented evidence. So when you can tell a patient that you can decrease their pain and it truly happens, and the data's out for a year, that has value to me. And if you improve their function, which Tenex has, in their studies, have used tools that are validated, that has a lot of weight with me. The one that sometimes you see is promotes tendon healing. There is evidence that the tendon will heal over time after you follow it out. But from my perspective, that's more disease-oriented, and it really doesn't matter to me. We want to know what matters to the patient. When I first started doing the fast, most often you get immediate results. I mean, we're talking after you do a plantar fascia case, they come back the next week later, and I have patients tell me, when are we going to do the other foot? But there are a subset of population that they're slow responders. And this happened to me a few times when I first started to do that, and I was like, well, what am I missing? What am I doing wrong? But I just had to be patient. And we'll talk about that case later, but it was a pole vaulter who I had to do 2 fast cases on. I mean, it's rare that you have to do 2 fast technique cases, but again, the amount of diseased tissue he had. And then there's that subset that are slow responders that they might not totally get benefit until 2-3 months after you've done a fast. In my reading, in Tenex literature, they have not reported any infection. I've had 1 localized skin infection after doing an Achilles tendon, which I treated with appropriate antibiotics, and it cleared up in 7 days. You can get swelling. Hematoma is reported, but I haven't had any of that. What I do after I do the procedure, which you'll see a live video of one, is if you, as you're doing the procedure, it's irrigating and aspirating. So for you do a tennis elbow, the elbow comes out, it doesn't even look like an elbow anymore. After you do the procedure, if you milk or push the fluid, excess fluid out, you can prevent a lot of that swelling that can occur.
Tom,
Yes.
what percentage of people are the immediate responders? What percentage of slow responders in what period of time you're talking about?
Yeah, so within in terms of quick responders are within 4 weeks, and the data from my review is around 52 to 60% when I reviewed the data. But a lot of the data is concentrated on tennis elbow and not as much data on lower extremity. And from my experience, lower extremity, certain cases are going to take longer. Does that answer?
Very good.
Yeah.
Thank you.
So the indications. A lot of the literature is here, it's coming here, but this is where most of the data has been derived from, when they sought FDA approval. But it's indicated for a wide variety of things here. Symptomatic spurs, let me touch on that. It's important to know that with doing the fast technique, you always talk with the patient about expectations. When I was first getting involved with the fast, I thought, wow, I was going to go in there and I was going to just take away all calcium deposition, spurs on the heels, supraspinatus, rotator cuff. But what I'm finding is, most often, number one, the primary pain generator is not the spur. So you have to know that. You have to attack the tendon first, because that's the primary pain generator. The spur, then you go after the spur with a higher energy, and the goal, if possible, the goal is to more debride or pare down. You're not going to be able to totally get rid of a spur. I have a case with plantar fascia. Her one spur was 2.5 centimeters. That's a very, very large spur. I saw her in follow-up recently, and I took my ultrasound and then I did a repeat x-ray to get a better measurement, and I was able to debride it down to 9 millimeters. So you're not going to be able to totally obliterate spurs or get all calcium, but you can help their symptoms by breaking up or paring down, debriding the spur.
Paring down with the fast technique.
Yes, you're using ultrasound energy with ultrasound guidance to debride diseased tendon, tendinosis, as well as spurs, or extra bone calcium.
So Achilles tendons are at risk of rupture. Are you worried when you're debriding away scar that you're...
Not at all. Not at all. We're talking millimeters of debridement, and that's the thing about the FAST technique. People always ask me this question, and that was one of my questions when I first started out. I was going to cause a rupture, a patellar tendon rupture, and I was like, I got to brace them and everything. But as I got more and more comfortable with the equipment, we're talking millimeters of debridement. And the nice thing about it, one of the hardest things about the technique is you need to know on ultrasound the characteristics of tendinosis. And that's what I started my lecture off with. You need to go after bad tissue. And not even, the engineering is set up that it only debrides necrotic tissue. But if you're poking with a needle, an 18-gauge needle at good tissue, you're definitely not, I don't think you're doing any good to it. So you have to go after necrotic tendinotic tissue. And we're talking about millimeters of debridement.
Now, do you vary the pressure on your debriding?
You do have to vary your pressure. So for example, on a tennis elbow, a mild tendinopathy, you're gentle. But I describe it like a woodpecker type, but you're gentle.
Do you have a gauge that can increase the volume that's coming through?
Yes, usually you're using medium to high power ultrasound energy. Commonly you're going for the common tendinopathies, medium power. When you go after a spur, you turn it up to high power. And you'll notice that when you use the handheld, it will warm up once you get high. You get a feel for it as the heat is being produced. So rotator cuff. One of the limitations as of right now for the FAST is that the needle is only 1.25 inches. So when you do your shoulder cases, you have to be patient selective. So meaning you can't have a large shoulder and do a good job, is my point. Because you only have 1.25 inches. And when you use an ultrasound probe, you need to account for whatever size ultrasound probe that you have. So when you only have 1.25 inch needle, you have to account for that. And because you have to sometimes get into the tendinopathy, but first you got to go through the deltoid and fat and skin to get there. But there is talk that they are developing a longer handheld device, about 2 inches, so that would be a big win. I put up here other tendinopathies. Some clinicians are using it for perineal tendinosis is one example, as it wraps a lot of diseased tissue as it wraps around the lateral aspect of the ankle, or posterior tibialis tendinosis. Again, another picture here. My ultrasound probe is here, and in the calcaneus and in the tissue. See how this is the top layer and the bottom layer of the plantar fascia? Right in the middle, this is all tendinosis. So that's diseased tissue. Again, another example flipped around. Better tissue, diseased tissue. Okay. So what you're going to see here that's the Tenix handheld device. This is the plantar fascia tissue. And this top layer is the tendinosis, the pain generator. Right here would be the heel bone. You don't see it because I have to be a little more distal from it. But the ultrasound is sending the signal and it picks up a needle which is hyperechoic. And you debride the tissue. You don't see it here, but sometimes you'll see a white crystalline substance on the top. That's common with the handheld device that produces that. That's the debridement that's going on. But your job, you have to target the tendinosis.
About a calcific tendinitis.
Yeah, I'll talk about that. Yeah. Okay, this is my, this is the gentleman I had to do 2 fast techniques on. I threw this line up here. This is the patellar tendon, ultrasound probe. The patient's head is here, his feet are here. So I drew this line in there, I put that line in there. The important thing to note is that this is all relatively healthy tissue. This is diseased tissue. It's about double the size of what it is. It took 2 fast techniques to treat him, and it was 2 minutes each time, twice. So it was a total of 4 minutes on 2 separate occasions. He lost his scholarship in college as a pole vaulter, but now, and his last follow-up appointment was about a month ago, he's back to running with minimal discomfort. He's not pain-free, but he's finally back to running. He couldn't run without having severe front knee pain. And this is the gentleman I always, when I give this talk, I threw everything at the kitchen sink at him. I tried PRP, I tried dry needling, I tried topical nitro. He had multiple good courses of therapy, including deep tissue massage to treat these tendinopathies such as Graston or active release technique. So he had a lot of things before we went to the fast. Again, another picture of it. This is the patella and the thickness of it. Now, before I go, so let me back up here. So you're seeing what we say from an ultrasound perspective. The probe is this way, and it's generating the long, on the long axis, the tendon, so from a lateral sagittal. When you see this next video, I had, because to get into the diseased tissue, I had to take my probe and turn it 90 degrees, so you'll be able to see the needle. If I did not do that, all you would see was a white speck coming at you. I prefer to see the whole needle when I'm going into tissue, and it helps me do, I think, a better job. This is the tendon, it's looking at you. And this is all tendinosis. Remember, this was better tissue on the sagittal. And then you start seeing the speckled appearance. You don't always get that. When I first started doing these, I was trying to get that. And just because you don't get it doesn't mean you're not doing a good job. So again, you see the needle debriding, and this is using on the ultrasound energy. Okay. So a diagram here where you have the, again, scar tissue or the tendinosis and your ultrasound probe, and then a handheld device will be coming in here to debride this area. Calcium deposition. Calcium has high reflection, so it's hyperechoic. This is one of my patients. Tendinosis more here, and often a common site is right up on that endpoint ridge on the elbow at the very tip. And this is a different case, but a lot more tendinosis, and you see the needle coming in and debriding. There was a large spur here. Often you'll go after that too with medium to high energy. But first you need to go after the tendinosis, and then you go after spurs.
Are you also debriding the bone there a little bit?
Yeah.
You know, with PNT, you're supposed to do that, but
To promote healing by hitting the bone with a needle. Yep. I mean, often, invariably, you will hit the bone, and
It's amazing that you can do this like in 1 minute.
yeah, it takes longer to set the patient up than to do the procedure. I mean, we're talking 30 seconds, 30 to 60 seconds for a tennis elbow. And I mean, that first picture that I showed you of the open procedure, you can only imagine the differences in healing time. I mean, this technique is as I said before, I believe a game changer.
People have used steroid shots extensively for tendinositis, and doesn't always work, but sometimes it does. Why should it work if there's no inflammation?
Good point. So the take-home message about steroids are, with time, and there was just an article came out in 2013, steroids treat pain. If it's an acute inflammatory response, then it can cure it if you're treating true inflammation. But a lot of these things, as you know, they become chronic, and they keep coming back, and they've had 3 or 4 steroid injections, and they say, well, it's not working as well, because over time people they don't respond to steroid because we're not getting to the root issue. The problem is scar tissue. So you can throw an anti-inflammatory or an injectable anti-inflammatory in there, and it's going to become less and less effective. The data shows that you actually start to harm tissue. So I mean, I still do steroid. I'm not against steroid. I mean, I've had one of my patients, she could barely walk, and I wasn't set up to do the fast on her that day, but she was in so much pain, I did a steroid for pain management. And that still has value. But the problem that I have is when they keep coming back and the provider keeps injecting with steroid, because the data shows you're actually harming the tissue. So if you keep injecting with steroid, you're doing the patient a disservice. You're not getting to the root cause. You might be putting a Band-Aid on something, but you've got to get to the root problem. Yes?
Does the presence of active inflammation affect your outcome? Like put the patient at risk if they have a lot of inflammation is more?
There is some data, people with other medical problems that delays healing. People that smoke delays healing. People with diabetes can delay healing. Active inflammation, that's something that I don't quite know the answer, but I will say this. A lot of our prior treatments to the FAST technique, what were we doing? We wanted inflammation. That's one of the ideas of PRP. You want to rev up the system. You want to excite the system to bring in the healing factors. What it's proposed from PRP, the platelet-rich plasma, is that we are bringing in the platelets that have all those healing factors, the cascades, the interleukins, to promote healing.
So the FAST technique would be used at the end of the process, not during the acute inflammatory process?
It would not be indicated, no.
About old folks versus young folks.
Great question. Let me answer that. So, age doesn't matter. The gentleman with the patellar tendon, you would think a younger person, healthy, he had no medical history. You think he should be a quick responder, right? It took him 4 months to respond. But then at the same time, I've had some military with, point-specific tendinosis within the supraspinatus. They've had 2 or 3 steroid injections, still having pain. They've had therapy, GRAST and ART come to me, and I do his tendon. I just had this case. It blew my mind away. He felt so good. He was lifting 70-pound furniture. He was lifting, his wife had to move this equipment or something around 70 pounds, and he did that a week later. And before that, he couldn't do that. It was amazing. But he was much older, and he was ready to retire from the military. And he had other medical issues too, but he was a quick responder. I don't know why. I don't have an answer for that. Does that answer that? Or?
Hi, this is Dr. Staley. Today I'm going to walk you through the FAST technique, and we'll watch how we set up a basic prep for most anatomy positions. As you can see in the short video, we're going to place the patient in a comfortable position, keep them nice and warm. We're going to put sterile blue towels around the area of pathology or anatomy in this case. The kit comes with ChloroPrep, so the area will be cleaned. In this case, we have a left lateral epicondylitis. First step in this procedure after they're sterilely prepped and draped and cleansed is to do an ultrasound visualizing the area of pathology. During this step, I use a marking pen. I'll hold the ultrasound probe so I can see the lateral epicondylar ridge, I can see the radial head and the area of pathology. In this case, you want to find the best angle to view the lateral epicondylar ridge. Once that's down, I'll mark it with a marking pen so I can go right back to it. I'll usually mark the midpoint of the probe. 10x handpiece actual needle is approximately 1.25 inches, so you don't want to start 2 inches back to go to the lateral epicondylar ridge. I like to view the anesthetic under the ultrasound probe as well, so I know I'm touching the epicondylar ridge. You can see from the video that the lidocaine is now being introduced right at the lateral epicondylar ridge. We're looking for the hypoechoic area, and we will use the anesthetic all around the area of pathology showing up on the ultrasound. During the procedure, we'll take an 11-blade scalpel, make a small skin incision, and take it down to the area of pathology. This facilitates the 10x handpiece getting to the area of pathology without much resistance. Once the small incision has been made, introduction of the handpiece is relatively easy, and it should be without much resistance. You can still see the marks on the patient's skin. It's inserted, and with ultrasound, we'll go directly to the area of pathology. You can see the actual tip of the device entering the area of pathology on the lateral epicondylar ridge via the ultrasound guidance technique. When performing this procedure, it's easier to use a gentle back and forth motion. It helps break up the degenerative tissue as well as the removal of the debris. It's important to note during this procedure to try to keep the ultrasound probe as still as possible, have the tip of the TX handpiece directly under the probe so you can visualize it at all times. The actual activation time takes approximately 35-45 seconds, sometimes up to a minute, depending on the area of pathology. It's important during the procedure to continually talk to the patient, make sure they're comfortable, having no pain.
Any pain?
After the procedure, it's easy to help some of the fluid removal with a little gentle pressure over the wound. As you can see, there's minimal bleeding with this procedure. The patient is then cleansed and a small steri-strip is placed over the wound. We use a folded 2x2 to cover that area of the steri-strip and the wound, and then a occlusive dressing is placed to make this waterproof. Following the FAST technique, standard protocol is Tylenol or Motrin for pain. The patient usually wears the ACE wrap for a few days, as we discussed. A clinic follow-up in 10 to 14 days is standard. If the patient should require pain pills, they are instructed to call my office and we can fill it typically for 1, maybe 2 days tops. Usually Tylenol or Motrin covers the pain. Patients are instructed to use ice if they develop any swelling or pain. With the minimal incision, we have not seen any infections. I'm a big fan of physical therapy. I think it will help decrease some of the inflammation and help with the range of motion after the FAST technique.
So for those that want to see the tendon afterwards, when I did this case, this region was pretty much all black. When I looked at it about 3 months later, actually about 2.5 months, it started to get that white appearance, which is a good sign. But again, remember what I said. What's more important is pain and function, not so much that it looks normal on an ultrasound. Yes.
You know, you showed a lot with that going in and out and out. What's the effect of the ultrasound probe on healthy tissue?
From the engineering standpoint, Merrick, how I understand it is that it's the way it's designed, it only goes after necrotic tissue. From when I spoke with one of the developers, Bernie Morey, he was having a hard time explaining it from the engineer standpoint. I'm just being honest with you. And I still don't quite understand how it doesn't hurt good tissue. It does blow my mind on how it doesn't hurt good tissue. It might have to do with the amount of time that you use on the tissue. Maybe that's why if you use more than 2 minutes, you start to harm good tissue. I don't know the best answer for that from an engineering standpoint.
So Tom, what they tried to do is, I'm Bill Stratton. So Bernie Morey's basic stance is this thing had to be really, really safe. And when you're talking specifically about Achilles, you have to make sure that we're not creating any type of eruption. So there's 28 megahertz of ultrasonic energy going across the tip of that. There's 28 megahertz of ultrasonic energy across the tip of that needle, and the engineering is such that at 1.3 inches, the 28 megahertz, you can sit that needle on top of
good tissue, yeah.
2 minutes, pushing that needle down before it becomes harmful. So if you're moving it the whole time with that kind of like back and forth fashion, which helps the aspiration as well, we're in a place where we don't have any type of harmful effects of the tissue at all.
So it's you have the 2-minute window basically, yeah. And I know
we're developing a 2-inch needle as well. That's coming at the end of the summer, which is going to be helpful for hips and shoulders as well.
Yeah. Yes.
The diagram at the inside of the instrument.
Of the
We looked at the outside of it, but I'm more interested in what's happening inside that instrument. In terms of there's a suction area, there's a ultrasound tip. What's happening inside that instrument?
Well, the way it's designed is it's sending ultrasound energy and irrigation, and then also aspirating. I just have the sample of the ones that I brought. If you want to take a look at it.
Yeah, no, I can get that for you.
But and then to answer, Merrick, your question, I do remember this is they did sit it on tissue for 2 minutes, and it was at 2 minutes it started to harm good tissue. Is that correct? I want to make sure that.
The reason we have the saline going across the tip of the needle is really for 2 reasons. One, to assist the aspiration of the pathological tissue out, which is one of the reasons why we did this, and 2 is to keep the tip of the needle cool.
Yeah.
So.
That's why, and another reason you have to be careful when you go on to high energy because the handheld will get very warm. Yeah, thank you, Bill.
Yeah.
Yes.
I know you're talking about upper body work. The national experience on the lower body, like heel spurs, are very problematic for people, are very disabling from the ambulatory standpoint. Can you tell us something about that, or is that going to be part of that?
Well, from my perspective, I think majority of the pain generator is the tendon. A couple of my patients had large heel spurs, and I can't debride it. I can only pare it down, debride it. I can't get rid of it. And the lady, she was on her last leg. She was either going to do the fast or she was going to have an open procedure because she was convinced it was the spur. I said, give me a chance to treat the plantar fasciosis, the tendinopathy. This is a lady that went from, I remember to this day, she could barely walk into my office to walking at a normal pace and having only 1 to 2 out of 10 pain. This is a lady that we tried everything with, and we didn't get her spur all the way down. So it's the diseased tissue. It's not all on the spur. That's why when you do the fast technique, you go after the diseased tissue first, and then you use whatever energy or time you have left on a higher energy to go after the spur. So the best you can do is pare it down or debride it in some situations.
In rotator cuff pathology, there's often a significant tear of the tendons involved. Does that influence whether or not you're going to attack them with your procedure? Or?
Yeah, so for rotator cuff, before the fast, it's the traditional, the older patient that isn't a good surgical candidate, but they have tendinosis, they have partial tears, and how I will approach it is I'll talk about expectations with the patient and use the FAST technique more from a pain management standpoint, because these are people, they come to me and I've done this. I've done 3 steroid injections, I haven't helped them. So if the expectations are usually, you have to bring them down. You're not going to get 80% success rate. I will only attempt to do the FAST on a patient that has significant pathology in the shoulders if I can get at least 50% success rate. Because a lot of times shoulder pain is not just from partial tears or tendinosis. There's significant spurs, arthritis. So it's more from a functional standpoint and pain management that I'll use it.
Can you attack the acromioclavicular joint itself and open up the...
I think you would be wasting your time. It's I don't know if Craig's done it or
I would agree. I think it's a waste of time in terms of getting there. The anatomy is such that you've got so much bone between you and that needle, and anything you take out is going to come right back in terms of that joint when it's mobile.
And I think some of the pain generation is not from the chronic tissue. The pain generation is from arthritis, loss of cartilage,
exactly.
exposed subchondral bone in the AC joint itself. So I don't think you're going to be treating the pathology.
No. So you have to listen to expectations with the patient. But then also remember, earlier on, one of the limitations right now is the needle is only 1.25 inches. So depending on how big your probe is, Craig and I have the mini, which helps us tremendously, but a lot of people have the moderate sized one. You're going to have a difficult time doing a shoulder, and maybe a difficult time doing an Achilles tendon, because you lose length because you only have 1.25 inches. But if the probe is this big, you've got to be precise with where your probe is and everything. It's very difficult to do it with the larger traditional linear probe.
I've seen bad Achilles tendons where there's a lot of, the tendon itself is like 2 or 3 times normal size.
Exactly.
You attack something like that? Or?
Definitely. But that's going that patient needs to know that they're not going to be ready to go in 6 weeks. They're going to probably be running at around 3 months' time, because you're right. When you see these Achilles tendons, it's almost double or triple the size of what the normal is. And also you need to let the patient know that, are we going to totally get that tendon to look like normal beforehand? You're not. The Achilles tendon, when you're doing the procedure, they're very, very bloody. You have to often use 2 entry sites, if not 3. Usually I use 2, and they're very labor intensive. You're not going to do it in 30 seconds. If you do it in 30 seconds, I'm hard pressed to say that you actually are going to make a difference, depending on the size, in all fairness, depending on the size of the tendinotic tissue. So, yeah.
So you diagnostically then to determine between an inflamed joint versus a tendinotic
tendinosis, yeah.
tendinosis.
So what?
You need this ultrasound. Is it
Well, you can.
definitive?
Well, a lot of times, to be honest with you, MRI misses tendinosis. MRI is very expensive. So what I do is I do a diagnostic ultrasound. Craig and I have been doing ultrasound for over 3 years. Craig did it before he came to Lourdes, but consistently, from my perspective, 3 years. And we use it as a diagnostic standpoint. And people will say, well, how do you know what you're looking at? Craig and I have done the CME. We've done from the beginning stages to advanced musculoskeletal ultrasound, and to have confidence that my MRI ordering has plummeted. And in a way it's good for the health system, for healthcare in general, because yeah, we might charge a limited diagnostic ultrasound. I can't remember. We're not getting the reimbursement of an MRI. We might be getting, I don't know, $80. Don't quote me on that, but it's by far a lot less, but it's more cost effective. The patient doesn't need an X-ray. They don't need an MRI. You can do a limited diagnostic ultrasound, identify diseased tissue, and then if you have diseased tissue, of course you're saving it and documenting, then the FAST technique would be appropriate for the patient.
you guys, you yourselves are reading the radio?
I read mine, Craig reads his. Yeah. I just recently sat for the boards for it. It's not required by insurances, but it's moving that way. I took my test in March, and I won't know until I think 3 or 6 months if I passed yet. But my kids asked me, well, did you pass, Dad? I said, I think I got more right than wrong. It's a joke. When you do diagnostic ultrasound, you have to just keep looking and looking and doing, and that's where you get your skill set. And that's when, once you get that skill set and you can identify, and then you get more comfortable with how you manage conditions. So this is what I'm currently working on. To prepare for this talk, I just pulled my last 10 cases of my plantar fascia. So for the sake of time, what I'm working on is doing an analysis of looking at cases that patients have had the FAST and see what they're doing a year later. And I'm doing this for one reason, to benefit clinicians in the community and to realize you need to have that, to have something independent of Tinnitus, to take away that bias. So I just, in my chart poll of my last 10 cases, I was looking at visual analog scale and lower extremity functional scale, and then seeing what my patients were doing before the FAST and what they were doing after. The lower extremity functional scale, it's a tool to evaluate function for the patient, and it's a tool used to monitor them after you do an intervention. So whether you're doing a therapy intervention, a steroid intervention, or FAST, you have a starting point, and then you have an ending point that you can measure at periodic time frames. The nice thing about this is it takes 20 questions. They fill it out in less than 3 minutes. The lower the score, the greater the disability. So my most recent 10 cases, these are what I just pulled last week. 3 out of the 10, they had the traditional plantar fascia release, and they were still 10 out of 10 pain, with no improvement from their visual analog scale. 5 out of 10 for the plantar fascia cases had had heel spurs. All have had therapy and some type of deep tissue massage, such as Graston or active release technique. 5 out of the 10 have tried some type of anti-inflammatory, and 6 out of 10 have tried orthotics. So they proceeded to go with the FAST because none of the traditional ways helped them. So pre-FAST, this is on average, their visual analog scale of those 10 was 8 out of 10. Post-FAST, 2 out of 10. Those cases that had the failed release, 2 of those patients had 0 out of 10 pain and are still 0 out of 10 pain. They were, and this is about 3 months for those. This is the nice thing that I like about it, because pain's important, but also function. On average of those 10, 34%, remember what I said, the lower the percentage, the more disability. After the post-FAST, 84% improvement on average. I have 4 of those that they were in 100%, meaning they were fully functional, no issues. The worst one was around 60%, so it affects the average. But this is amazing to me, because when I'm doing an intervention and then I see objective data with my patients, that carries more value. And it lets me be able to monitor my patients closer, as opposed to all my patients get better. I have some objective data to look at. So I'm going to be working on getting some IRB approval to look at this, and I'm hoping to publish something to benefit the medical community. So finishing up here, post-FAST, a lot of people talk about protocols. The protocols are new. In all fairness to Tinnitus, there's not a lot of science, at least from my perspective. I think they just pull things out, and it's where we start with protocols and then we modify them. So a lot of times, when I first started doing, for example, my shoulders, I was putting them in the sling for a few days, and I found out that I was causing more harm. I was causing them to start to get tight and stiff. So they're only in a sling a day, and then I get them doing movement, gentle range of motion. People ask me, well, you're supposed to do therapy after you do the fast. Most of the time, majority, I don't even do therapy. They've done their therapy. They know their home program. Sometimes I don't even have them do any eccentrics, because remember, we're going in there with an 18-gauge needle. We're promoting healing by debriding tissue, but we're also causing some inflammation. So sometimes just stepping back and sitting on your hands and let them just do their activities of daily living with letting them know that they're not supposed to be doing repetitive lifting, pushing, pulling, or lifting greater than 5 pounds. And they often do well. I rarely prescribe therapy afterwards. Follow-up can be 1-6 weeks, but again, remember, my lower extremity, I'm seeing them further out because I have to approach them case by case and advance them when they're ready. That includes advancing their home program, which I'm teaching them all along, whether it be an eccentric stretch or just no stretching at all, just letting them get out of the boot and walk. Upper extremity, I'm a big fan of Play-Doh. They don't need to go do therapy afterwards. So, perfect timing. Nice. Great. Lastly, I have. So I want to introduce you, Master Sergeant Sean Verapin. He serves in the military, and I brought him along because he has a lot of useful information because he's a patient that had the fast, and I'm going to give him a time just to tell his story, and you can ask him about his experience and what he went through. So,
good evening, ladies and gentlemen. It's my pleasure to be here this evening, speaking on behalf of Dr. Plut and my experience that I've had with the fast procedure. I deployed to Afghanistan in June of 2011. Approximately a month to a month and a half after getting over there, I started to experience a lot of pain in both feet, especially in the morning. When I got up, I found the first 15 minutes or so of awaking and walking around, pain scale was a 9 to 10. It was absolutely painful. I attributed it at that time to the hot weather, the rocky terrain that they had over there. I didn't pay much mind to it. After about the 3rd or 4th month, I couldn't take it anymore, and I wound up going to the medical facility over there. Not much treatment over there in Afghanistan. You're in a war zone. Basically wear sneakers for 2 weeks, and when you get back to home station, take care of it. Upon coming back, I was seen by the medical treatment facility at McGuire Air Force Base in Wrightstown, New Jersey. And at that time, I had a referral to see Dr. Plut. My first visit to Dr. Plut, I went in, I explained my pain, I explained what happened, where I was. And initially, he had prescribed physical therapy for me. So I went to a NovaCare rehab, and I did my physical therapy there for a couple of months, I believe it was. And at that time, they used the Graston tool. That was the main thing. I did some stretching and some exercises. They had me picking up marbles or something like that. Didn't work. Still experiencing a lot of pain, especially wearing the military boots. They are not the most comfortable boots or shoes to wear in the world. So after the physical therapy, I went back for a follow-up with Dr. Plut at that time. He did offer me a few options. We had inserts for the shoes. I remember the second option, if I'm correct, were cortisone shots. And the last option he offered was a fast procedure, which he explained was a relatively new procedure, but they had a high percentage of a success rate for that procedure. But the option was mine to decide which way I wanted to go. I'm thinking to myself, well, I just want relief from the pain, so why put in any inserts, go through the cortisone shots, you have to come back and do it again. Why not try something that will help alleviate the pain? So I believe it was just after New Year's, January of this year, I went in for the first fast procedure, which was on my left foot. Before I go any further, let me just make a little clarification. I have a slight limp this evening, but that is because I had a knee surgery a few weeks ago. It has nothing to do with the plantar fascia that I had. I just want to make sure that's clear there. Okay, correct. So I had the first procedure. It was a relatively simple procedure. As I state to anyone that I speak to about it, the worst part of it was getting the lidocaine, the needle stuck into the bottom of your foot. Little uncomfortable, but after that, you don't feel anything. I was out of work for approximately 2 weeks, give or take, and in between that time, Dr. Plut did prescribe. They started off with mild stretches and they progressed along as each week went along. The stretches got a little more intense. By, I would have to say, week 4 after the FAST procedure on my left foot, I had to go back in for the right foot. When I came back in, I explained to him that I felt absolutely, and this is amazing, I felt absolutely no pain whatsoever. To this date here, absolutely no pain in my feet following the FAST procedure. I went from a 9-10 pain to absolutely 0. Now, prior to me going to have the FAST procedure, I used to do a lot of running. I was a cross-country runner, and I would do about 25-30 miles a week. Prior to going in for the FAST procedure, it was difficult sometimes just walking around or standing up here as I'm speaking in this forum. It would have been excruciatingly painful. Now, I'm standing here, I'm speaking to you, and I can tell you that the FAST procedure worked for me, all right, and it's been a big success for me. I'm extremely happy with the results that I have received from this procedure, and I am able to, well, barring my limitations now, but prior to this, full function, was able to go back and do my walk, running, exercising. So for me, I have to say it was a true success. I'm not sure if there's any questions that you have for me regarding my experience that I've had with it. The first week and a half was a little sore, but that was from the incision site. After week 3, that started to go away, but what I felt almost immediately, I'd say within the first 3 weeks, was the pain that I experienced along the bottom portion of the foot was not there anymore. So it was almost an immediate difference. Anything?
You were non-weight bearer?
No.
No. Now the only thing that that I did was I walked around. I did what I could do, as much as I could do, but I performed my daily functions. And as time went along, of course, the pain was a little less and less. But it was.
I don't even need questions.
Correct. It was just, I believe, the first.
I put him in a boot for a week.
Correct. That's correct. I was in the boot for approximately 1 week. After that, I was walking around, and I was absolutely. It was fine. It was fine. Yeah. Anything else, Doc? I don't know if you going once, going twice. All right. Well, listen. Thank you very much. Also, again, I'd like to thank the folks at Tenix. All right. Thank you. All right, Doc. I'll be in the back of it. Okay.
That's it, guys. My 4th child, she keeps getting left out in the picture. She'll get in one of these days. But thanks for coming. I really appreciate it. I hope this was beneficial to everyone. And I'll be around afterwards to answer any of your questions. And that's all. Thank you.